Welcome to the deep dive. Today we're looking into something called renal artery aneurysms, RAAs for short.
Right.
Now, you probably don't hear about these every day, which honestly makes the research we're digging into even more interesting.
That's right. We're pulling insights from 50 landmark papers every vascular and endovascular surgeon should know. Specifically, a really key study. It was published back in 2015 in the Journal of Vascular Surgery.
By the Vascular Low-Frequency Disease Consortium, yeah.
That's the one. A big collaborative effort.
Okay, so our mission for you today is to really unpack what this landmark paper showed us about RAAs. We want to get a good grasp on, what they actually are, how doctors have typically managed them.
And crucially, whether this sort of standard thinking about when to treat them might need a bit of an update.
Exactly. Think of this as your fast track to the key takeaways. Okay, let's dive in. First off, what exactly is a renal artery aneurysm?
So the study gives a pretty precise definition. Picture the artery that feeds blood to your kidney. An RAA is like a localized bulge or ballooning out of that artery wall.
Okay, a bulge.
Yeah, but specifically, the study defined it as a widening involving all 3 layers of the artery wall, and it has to be more than 1.5 times wider than the healthy artery right next to it.
Ah, so quite specific, not just any widening.
Right. It's a focal, isolated dilation. That's the key technical part.
Got it. And are these common? You said low-frequency disease earlier?
Yeah, they're considered rare. The estimate is maybe around 0.1% in the general population. Pretty low.
Wow, okay.
But, and this is interesting, we are finding them more often nowadays.
Oh, why is that?
Well, it's mainly because we're using cross-sectional imaging, things like CT scans, much more frequently for all sorts of other medical reasons.
Right, so people get scanned for something else entirely.
Exactly. And then, oops, there's an RAA that nobody knew about. So it's not that they're necessarily becoming more common, just that our ability to spot them has gotten way better.
That makes perfect sense. So this 2015 study was pretty big, wasn't it?
Yeah.
What were the main things they found out about these RAAs?
Oh, it was huge, yeah. They pulled data from 16 different institutions looking at 865 RAAs in 760 patients. That's a lot of data.
Definitely.
And maybe one of the most striking findings was how often these things just sit there quietly. No symptoms at all.
Really? How long?
A full 75%. 3/4 of the RAAs in this massive study were completely asymptomatic.
Wow. 3 out of 4. Silent. So what about the other 25%? What kind of problems were they causing?
Well, the most common issue reported in about 10% of the symptomatic cases was hypertension, high blood pressure that was difficult to control.
Okay, tricky high blood pressure. Anything else?
Some people had flank pain, kind of pain in your side. That was about 6%. Then hematuria, which is blood in the urine, that was 4%, and some general abdominal pain in 2%.
So, a few things. But nothing that screams renal artery aneurysm immediately, I guess.
Not usually, no. And what about the aneurysms themselves? Did the study paint a picture of what they typically look like?
Yeah, do they have common features?
They did. The average size, the maximum diameter, was about 1.5 centimeters. Plus or minus a tiny bit, of course.
Okay, 1.5 centimeters on average.
And almost always just on one side, 96% were unilateral. More often on the right side, actually, about 61%.
Interesting. Right side more common.
Yep. And shape-wise, most were saccular. That means kind of like a little sac or pouch sticking out. That was 87%. And quite often, they had calcification in the walls, like hardened deposits. That was seen in 56%. Oh, and location frequently found right where the main renal artery splits into smaller branches at the bifurcation.
Gotcha. Okay, now, the big question with any aneurysm, rupture, bursting. That's the main fear, isn't it? What did this huge study find about the risk of RAA rupture?
This is probably the most practice-changing finding, I'd say. The study showed that for these asymptomatic RAAs, even the ones a bit bigger than 2 centimeters, rupture is actually very rare.
How rare?
Incredibly rare in this cohort. The overall rupture rate was only 4.03%. Tiny.
0.03%, that's almost negligible.
Pretty much. And here's the kicker. Every single rupture that did happen in their study occurred in an aneurysm that was larger than 3 centimeters.
Okay, that's huge. So nothing under 3 centimeters ruptured in this large group.
Correct. Which really suggests that for many people with these smaller asymptomatic RAAs, the previous sort of standard advice to consider fixing them above 2 centimeters might have been, well, maybe a bit overly cautious.
That's a massive implication.
Yeah,
So the worry about smaller ones might have been, let's say, disproportionate.
that's certainly what this data suggests, yes. The study also looked at growth rate, right? How fast do these things get bigger?
Ah, yes, good point. What did they find?
They calculated an average growth rate of about 0.086 centimeters per year, so less than a millimeter per year on average.
Pretty slow growth then.
Generally slow, yes. And another important detail. They found that having calcification in the wall didn't stop the aneurysm from growing. Sometimes people thought calcification might make it more stable, but that wasn't the case here.
Okay, so calcification doesn't mean it won't grow. Good to know. So given all this, how were these RAAs actually managed in the study population? Did most people get surgery, or were they watched?
It was a mix. Elective repair plan surgery was done for 241 RAAs in 213 patients. That's about a quarter of the patients.
And why did they get surgery?
Typically, it was either because they had symptoms attributed to the RAA or because the aneurysm was larger than 2 centimeters. That was the common threshold for intervention at the time.
Right, the old guideline.
Exactly. The rest of the patients, the majority with 624 RAAs, were managed conservatively. Basically observation with regular checkups and imaging.
Okay. And for those who did have a repair, what methods were used?
Two main approaches. Traditional open surgery, which is obviously more invasive, and endovascular repair using stent grafts.
The less invasive option.
Right. The endovascular route was mostly used when the aneurysm was in the main trunk of the renal artery, where it's often easier to place a stent graft.
Makes sense.
Yeah.
And what about the outcomes for the surgery group? Was it smooth sailing?
Not always. The study reported major complications in 10% of those who had surgery.
10%. What kind of major complications?
We're talking serious things like multi-system organ failure, heart attacks, kidney failure needing dialysis. So not insignificant risks. They also mentioned significant minor morbidity, especially with the open repairs.
Okay, so the treatment itself carries real risks. But did it help with the hypertension issue for those patients?
Yes, that's one area where repairs showed a clear benefit for some. For patients whose RAA was found during the workup for hard-to-control high blood pressure, the repair actually cured the hypertension in 32%.
Cured it completely?
In about a third, yes. And it improved the blood pressure control in another 26%. So a positive impact on hypertension for a decent chunk of those specific patients.
That's certainly a benefit worth noting. And what about the ones managed without surgery? The observation group. How did they fare over time?
They were followed for quite a while, an average of 49 months, so just over 4 years. And during that follow-up period, there were no acute complications reported in that group. No ruptures, no sudden issues.
4 years of follow-up with no major problems. That's pretty telling, isn't it?
It is. And it leads directly to the big takeaway, really. Does this study mean we need to fundamentally rethink how we treat RAAs?
It sounds like it challenges the status quo quite a bit. The previous guidelines seem based on maybe older, less robust data.
That's exactly the point the study authors make. The older guidelines often suggested fixing RAAs if they caused symptoms were bigger than 2 centimeters or were found in women of childbearing age, partly due to rupture concerns during pregnancy.
Right.
But those recommendations often stem from older case series, maybe with publication bias towards reporting ruptures, which reported higher rupture rates. This large contemporary study suggests the actual risk, especially for asymptomatic RAAs, is much lower.
So that 2 centimeter threshold may be too low.
Potentially too aggressive for many asymptomatic patients, yes. That's the implication.
So what did the study authors themselves propose? A new threshold?
Based on their findings, the low rupture risk under 3 centimeters and the slow growth rate, they suggested that maybe a size threshold of 3 centimeters would be more appropriate for considering intervention in asymptomatic cases.
3 centimeters instead of 2?
Yes. They calculated that raising the threshold to 3 centimeters could mean a significant percentage of asymptomatic aneurysms might safely avoid surgery for at least 10 years.
Wow. And has this thinking started to filter into official guidelines?
It appears so. The paper mentions that the Society for Vascular Surgery was, at that time, drafting new clinical practice guidelines.
Okay.
And that these new guidelines were considering recommending treatment for non-complicated RAAs, primarily when they reach a size greater than 3 centimeters.
So this study likely had a direct impact on that shift.
It certainly seems like very strong evidence supporting that change.
Now, you mentioned it was a large study, but no study is perfect. Did it have limitations we should be aware of?
Definitely. The authors were upfront about them. It was retrospective, meaning looking back at past records. So you can't be 100% sure all RAAs were captured, and there might be selection biases.
Right, looking backward has its challenges.
Also, the imaging wasn't standardized. Different hospitals use slightly different protocols or types of scans, which makes it a bit harder to make definitive statements about the absolute best way to image or follow these.
Understandable limitations for a multi-center retrospective study.
Yeah.
But overall,
Overall, it's a landmark paper for a reason. It provided a huge amount of modern data that seriously questions the old dogma. It really underscores the need for ongoing research to perfect, who really needs treatment and what the best approach is for each individual.
okay, so let's crystallize this for you, the listener. What are the absolute key takeaways from this deep dive on renal artery aneurysms?
I think the main things are, first, asymptomatic RAAs seem less dangerous than maybe we once thought.
Okay, lower risk.
Yeah, they tend to grow slowly, and that critical risk of rupture, especially below 3 centimeters, appears very low based on this large study.
Much lower than the older 2-centimeter thinking suggested.
Exactly, which means the traditional trigger point for considering intervention, that 2-centimeter mark, is now being seriously questioned, maybe leaning towards 3 centimeters for uncomplicated asymptomatic cases.
Right. It really changes the risk-benefit calculation for treatment.
It does.
And finally, just a thought to leave you with. This study is a great example of how medical knowledge evolves, isn't it?
Absolutely.
It makes you wonder, how often should we be formally revisiting established treatment guidelines across all areas of medicine based on new, large-scale data like this? What's the real power of collecting this kind of big data in challenging long-held beliefs and making sure care is truly up to date?
It's a crucial question. How do we best integrate new evidence to make sure we're not intervening too much or too little?
Definitely food for thought. Thanks for joining us for this deep dive.